Type 1 diabetes mellitus, T1DM, is a chronic autoimmune condition characterized by the destruction of pancreatic beta cells, the specialized cells responsible for producing insulin. Without insulin, the body cannot effectively regulate glucose, leading to persistent hyperglycemia and profound metabolic disruption. Unlike type 2 diabetes, which is associated with obesity, insulin resistance, and lifestyle factors, type 1 diabetes arises primarily from an immune-mediated process. It accounts for approximately 5–10% of all diabetes cases worldwide, but despite its relatively lower prevalence, its impact is disproportionately large due to the lifelong nature of treatment, the risk of serious complications, and the psychological burden it imposes. The condition most often appears in childhood, adolescence, or early adulthood, though it can develop at any age. Diagnosis frequently comes suddenly, sometimes in the context of diabetic ketoacidosis, a life-threatening emergency. Living with type 1 diabetes requires a continuous commitment to glucose monitoring, insulin administration, dietary management, and vigilance against both short-term and long-term complications. Over the past century, treatment has advanced from crude forms of insulin delivery to sophisticated technologies such as continuous glucose monitoring, CGM, insulin pumps, and hybrid closed-loop artificial pancreas systems. Despite these innovations, a cure remains out of reach. Understanding the disease in detail, from its physiology to its psychosocial impact, remains essential for clinicians, patients, researchers, and policymakers alike. To appreciate the disruption caused by type 1 diabetes, one must first understand the physiology of glucose regulation. Glucose serves as the body's primary energy source, fueling processes in nearly every cell. After a meal, carbohydrates are broken down into glucose molecules which enter the bloodstream. Rising blood glucose stimulates pancreatic beta cells located within the islets of Langerhans to secrete insulin. Insulin acts as a key that allows glucose to move from the bloodstream into target tissues. In muscle cells, insulin promotes glucose uptake and its storage as glycogen for later energy use. In adipose tissue, insulin facilitates the uptake of glucose and its conversion into triglycerides while also suppressing fat breakdown. In the liver, insulin stimulates glycogen synthesis and inhibits glucose release into the bloodstream. Counter-regulatory hormones, including glucagon, cortisol, growth hormone, and adrenaline, serve the opposite function, raising blood glucose when it drops too low. This balance maintains glucose levels within a narrow physiological range, typically 70–140 mg/dL, 3.97–8 mmol/L. In type 1 diabetes, the near-complete absence of insulin destroys this balance. Glucose accumulates in the bloodstream, while cells starve for energy. Fat breakdown accelerates, leading to ketone production and the risk of metabolic acidosis. Type 1 diabetes is primarily an autoimmune disorder. For reasons not entirely understood, the body's immune system misidentifies beta cells as harmful and mounts an attack against them. The process involves immune cell infiltration. T lymphocytes penetrate the pancreatic islets, producing inflammation known as insulitis. Beta cell destruction. Cytotoxic T cells directly kill beta cells, while autoantibodies mark them for immune targeting. Progressive insulin deficiency. Over months to years, the beta cell population dwindles until insulin production falls below a critical threshold. Autoantibodies provide early evidence of the disease process. Commonly measured markers include anti-glutamic acid decarboxylase, anti-JADE antibodies, insulin autoantibodies, IAA, islet antigen 2 antibodies, IA2, zinc transporter 8 antibodies, ZNT8. By the time symptoms appear, 80–90% of beta cells are typically destroyed. At this stage, endogenous insulin secretion is insufficient, and without external replacement, life-threatening metabolic crises develop. At this stage, endogenous insulin secretion is insufficient, and without external replacement, life-threatening metabolic crises develop. Type 1 diabetes results from a complex interplay between genetic predisposition and environmental triggers. Genetics. Certain variations in human leukocyte antigen, HLA genes significantly increase susceptibility. The HLA-DR3 and HLA-DR4 alleles are most strongly associated. However, genetics alone is not deterministic. Even in identical twins, the concordance rate is only about 30–50%. Autoimmunity, the immune system's loss of tolerance for beta cells, is the defining factor. Presence of multiple autoantibodies predicts a very high likelihood of future diabetes. Environmental triggers. Viral infections such as enteroviruses, mumps, and rubella have been implicated. Early dietary exposures, including cow's milk proteins in infancy, are under study. Vitamin D deficiency has also been linked to increased risk. Geographic variation. Incidence is highest in Northern Europe and North America, with Finland and Sweden among the most affected. Rates are lower in East Asia and South America. Other possible factors: changes in gut microbiota, psychosocial stress, and perinatal influences are emerging areas of research. The cause is therefore multifactorial, and no single factor is sufficient to explain disease onset. The clinical onset of type 1 diabetes is often abrupt. Classic symptoms include polyuria, frequent urination due to osmotic diuresis caused by glucose spilling into the urine; polydipsia, intense thirst triggered by dehydration; polyphagia, increased hunger as cells cannot effectively utilize glucose; unexplained weight loss. Fat and muscle breakdown accelerate in the absence of insulin; fatigue and irritability. Energy deprivation at the cellular level leads to reduced vitality and mood disturbances. Blurred vision. Hyperglycemia causes temporary changes in the lens of the eye. In children, presentation may be dramatic, sometimes with diabetic ketoacidosis, DKA. Symptoms include abdominal pain, vomiting, rapid breathing, fruity-smelling breath, and altered consciousness. DKA is a medical emergency with significant mortality risk if untreated. The rapidity and severity of onset distinguish type 1 diabetes from type 2, which typically develops more gradually. Diagnosis relies on established criteria: fasting plasma glucose, 126 mg/dL, 7.0 mmol/L; random plasma glucose, 200 mg/dL, 11.1 mmol/L, with symptoms 2-hour plasma glucose, 200 mg/dL after oral glucose tolerance test, HbA1c16, 5%. Additional investigations help clarify the type. Autoantibody testing confirms autoimmune origin. C-peptide levels, low or absent in type 1, reflecting lack of insulin production. Routine screening of the general population is not performed. However, in research or family settings, individuals with relatives affected by type 1 diabetes may be screened for autoantibodies to assess risk. Type 1 diabetes carries risks of both acute emergencies and long-term complications. Acute complications. Diabetic ketoacidosis, DKA, caused by severe insulin deficiency leading to ketone accumulation and metabolic acidosis. Without rapid treatment, it can be fatal. Severe hypoglycemia, often a side effect of insulin therapy, resulting in confusion, seizures, or loss of consciousness. Chronic complications. Persistent hyperglycemia damages small and large blood vessels over time. Microvascular complications, retinopathy, blindness, nephropathy, chronic kidney disease, neuropathy, numbness, pain, and autonomic dysfunction. Macrovascular complications, cardiovascular disease including heart attacks and strokes. Other complications, increased infection risk, poor wound healing, diabetic foot ulcers leading to amputation. Effective glucose control dramatically reduces, but does not eliminate these risks. Type 1 diabetes requires lifelong insulin replacement. Modern management is multifaceted. Insulin therapy, multiple daily injections, MDI, combination of long-acting basal insulin with rapid-acting bolus insulin before meals. Insulin pumps, deliver continuous subcutaneous insulin allowing fine-tuned control. Closed-loop systems, integrate CGM data with insulin pumps using algorithms to adjust delivery automatically. Glucose monitoring fingerstick testing remains common. CGMs provide real-time data, trends, and alerts, improving safety and control. Diet and lifestyle carbohydrate counting helps match insulin doses to food intake. Regular physical activity enhances insulin sensitivity but requires careful monitoring to avoid hypoglycemia. Balanced diets with attention to fiber, fat, and protein intake support overall health. Education and self-management. Patients and families are trained in insulin adjustment, recognition, and treatment of hypoglycemia, sick day management, and ketone testing. Management is highly individualized, balancing medical effectiveness with lifestyle preferences and psychosocial factors. Living with type 1 diabetes imposes a constant psychological and social burden. Emotional stress. The unrelenting need to monitor glucose and administer insulin creates anxiety and fatigue. Fear of hypoglycemia. Episodes can occur unpredictably, affecting independence and confidence. Social stigma. Some children and adults face misunderstanding or discrimination in schools, workplaces, or public settings. Family impact. Parents of children with type 1 diabetes often experience stress, sleep disruption, and heightened vigilance. Mental health. Rates of depression, eating disorders, and diabetes-related distress are higher in this population. Comprehensive care requires attention not only to medical treatment, but also to psychological support, community resources, and peer connections. Exciting areas of research are underway. Immunotherapy. Efforts to halt autoimmune destruction using monoclonal antibodies, vaccines, or immune-modulating agents. Beta cell replacement. Transplantation of pancreatic islets or stem cell-derived beta cells offers potential long-term insulin independence. Encapsulation technologies. Protect transplanted cells from immune attack without systemic immunosuppression. Artificial pancreas systems, combining CGM, pumps, and advanced algorithms to mimic physiological insulin regulation. Prevention trials, exploring early interventions in at-risk individuals, such as teplizumab, to delay disease onset. While no cure exists yet, these advances promise to improve quality of life and move closer to disease-modifying therapies. Type 1 diabetes is a lifelong, immune-mediated disease that profoundly impacts individuals, families, and healthcare systems. It begins with a breakdown of immune tolerance, progresses to the destruction of pancreatic beta cells, and results in the absolute need for insulin replacement. Its complications, both acute and chronic, make vigilant management essential. Thanks to advances in insulin formulations, delivery technologies, and glucose monitoring, life expectancy and quality of life for people with type 1 diabetes have improved dramatically. Yet challenges remain. Psychosocial burdens, unequal access to technology, and the continued absence of a cure underscore the need for continued research and comprehensive care models. The future holds promise. Immunotherapies, regenerative medicine, and artificial pancreas technologies are on the horizon. Until then, the focus remains on empowering patients through education, support, and innovation to live full and healthy lives despite the condition. Until then, the focus remains on empowering patients through education, support, and innovation to live full and healthy lives despite the condition.